This is the EMS Research Vlog and Podcast, where we talk about the research-related issues that matter to those who work or study in the area of emergency medical services. Your host is Bram Duffee, who is a paramedic and communications professor.
Welcome to today's show. I'm thrilled you could join us as we explore emergency healthcare and cutting-edge technology. By now, many of us have heard about AI tools like ChatGPT, but have you ever wondered how they might be improving patient care? Specifically, could these tools assist paramedics in making faster, more accurate decisions? Well, today, the plan is to break down and look at a recent research study that's called Accuracy of Commercial Large Language Model, ChatGPT, to predict the diagnosis for prehospital patients suitable for ambulance transport decisions. Big title, but we're going to unpack how researchers tested ChatGPT's ability to identify patient conditions from paramedic records and then really see what that means for EMS. But that's not all, because joining us later, we will have one of the lead researchers behind the study with us. And we'll get the inside scoop on their motivations, the challenges faced, and sort of the whole vision for this AI healthcare stuff moving forward. So stick around because you're in for a fascinating discussion about the future of emergency medicine. So what was this study all about? You know, ChatGPT is a powerful AI model, but this study put it to the test because this is a high stakes environment when we look at emergency medical care, right? And the researchers wanted to know if ChatGPT could predict accurate diagnoses for patients based on pre-hospital patient care reports. And the key question was simple, but it was important because we wanted to say, hey, how well can ChatGPT match its diagnosis to those made by experienced paramedics? And they were wondering, like, could this tool improve decision-making about where patients can get taken in an emergency? And so the study also looked at disagreements between these human and AI diagnoses that we see, that we identify, and we look to see who's more likely to be correct in those situations. So here's how they ran the study. The team analyzed 104 patient care records from a paramedic student database. And for each case, ChatGPT was asked to identify the most likely diagnosis based on the patient's history and symptoms. And they compared ChatGPT predictions to those made by experienced paramedics, who created the reference diagnosis. So when ChatGPT and the paramedics didn't match, then they had two emergency physicians stepped in and just made the determination which was more accurate. And the results were eye-opening because ChatGPT correctly predicted the diagnosis 75% of the time. But more importantly, there was a disagreement. ChatGPT identified conditions as being more critical in 46% of the cases. And that means that while AI isn't perfect, it's conservative, and this conservative approach might reduce under triage, right? And then as a result, ensure fewer serious cases that might get overlooked. So the good news is that the safety profile for ChatGPT was strong. And out of the 104 cases, there was only one instance where the AI might have recommended an inappropriate transport decision. And this promising stuff is pretty cool because it really helps us see that given that emergency situations often benefit from quick decision making, and this might be helpful, but the study also makes it clear that there is some room for improvement because AI should be viewed as a tool just assists, and when we assist healthcare workers, it's a lot different than replacing what's going on with their experience in the environment. And that brings us to our next segment because we want to understand the real world implications of this. And I'm excited to say that Eric Miller is going to join us. He's the lead researcher on the study, where he can talk about his insights. So, I want to share with you that Eric Miller lives in Colorado Springs, Colorado, and he's a lieutenant colonel in the U.S. Air Force Reserves and is a psych mental health nurse practitioner and has been a paramedic for 40 years. So he completed a fellowship in disaster medicine at Beth Israel Deaconess Medical Center, Harvard in 2024. And altogether, he's here to talk about his research and work in AI with differential diagnosis. So, welcome to the show, Eric. Thank you for joining us today. And just tell us about your background so that we can all get to know you better.
So you can see from my hair, Bram, that I've been around the block a little bit. I I'm just a little country paramedic from Colorado Springs. I'm not I got to do this fellowship in Boston last year, and through that was introduced to some pretty high level researchers and that type of stuff. And so this research project came out of my fellowship in Boston. And so, as you said, this is about AI and differential diagnosis. We're not boiling the ocean here. This isn't some earth-shattering research, but it does set the foundation. It is the first research project that we've been able to identify on AI and pre-hospital differential diagnosis. So, as you said, we pulled from a database, student database, from a large paramedic training facility near Boston. We had over 1,000 different care reports, and we narrowed those down to 104. A couple of things that we excluded was substance abuse and psych diagnosis. The reason we pulled psych out, with my background being psych mental health nurse practitioner, I can tell you that, for paramedics, most of us is, give them some Haldol, and that's our treatment. But really, you get into the DSM-5, it gets very complicated when you get to the diagnosis for psych patients. And rather than muddle that, we just excluded them from the cases. So we narrowed those cases down, and we've had 5 different paramedics, all experienced between 15 to 45 years of experience. The smallest population that they served was 8,500, but the largest was about 1.4 million. We had a flight medic from Boston area, and then we had a paramedic out in San Diego, and then some paramedics across the country.
So that's the question I was having is when I'm thinking about where did all these folks come from? Because you use student records and not real medical records, right? So tell me about that design part.
So from your PhD, and actually I looked up your dissertation. So this is really interesting that there's some real correlation between our research and your research on differential diagnosis. So the reason we use student reports is that they're very easy to anonymize. I don't know if that's the correct pronunciation, but basically, when we went to do an IRB, when you do research, you have to do an institutional review board. It was very simple with using the student database to be able to get a waiver from the IRB versus a huge review process, which could take months. This one, because we were able to prove that without question, there's no way to take these reports back to who the actual patient was. So we got a waiver from the Beth Israel Deaconess Medical Center IRB board. So that was the primary reason.
And I want to make sure I understand. So what happens is paramedic students go and do clinicals, and so they are seeing real patients, but then this is just like their fake report that they're learning from that they're making, or are these total case studies?
No, these were their actual reports from the patients that they were seeing. They weren't
All
made
right.
up. And so this goes into, a database that we basically pulled the subjective objective out. And that's the only ones that we use. We tried to find most of those cases also had something in the plan where it discussed what the ER, maybe what the discharge diagnosis or admitting diagnosis was, so that we had an idea, but that was not given to the paramedic reviewers nor to the educators. That we had 2 doctoral EMS educators around the U.S. That that looked at the paramedic diagnosis and the chat diagnosis, and they were the initial review of was there agreement or disagreement. If there was disagreement, then it went to two board certified emergency physicians that decided which one was more correct.
So I think about studies like this, and I've found that studies that show how paramedic differential diagnosis doesn't always match up with the ER doctor's differential diagnosis, So it's like the paramedic might put on their report that their differential diagnosis is congestive heart failure, but when all of the tests that the hospital has available to them allow them to decide it's not CHF, it's actually COPD, or something like that. But so when we're trying to match up these diagnoses, were there any concerns along those lines about what information is available, and will that information skew results because of the nature of the information?
Yeah, I think that's a really good point. And I don't know that that was taken into account. I think that the problem will still exist because in the um, in the pre-hospital setting, you don't have all of the information that they're going to have in the ER. So you're still going to have that that end diagnosis mismatch in some cases. Again, I haven't seen the study where paramedic diagnosis and the ultimate ER discharge diagnosis. I haven't seen that study. I'm aware of it. But I don't think that is one, it wasn't addressed in this study, but I don't know that that goes away because you simply don't have information
Mhm.
that the ER docs or the ERs are going to have. And whatever AI product that you use isn't going to have that information either. And so it
Mhm.
bases its diagnosis on whatever the information is that's available.
So this found out, or this study really says that, hey, ChatGPT often makes diagnoses that are more critical than paramedics would. So when you plug in this information, why is it skewing more towards a concern for a worse diagnosis or a more critical patient?
So I don't know that that's known. I can tell you, so there's a couple of things. I've got some notes here so that I make sure that I don't screw it up. We had one of the reasons I think paramedics don't do research is they're terrified of the statistics. And so we were very fortunate to have Dr. Jeff Frank with Stat 59, who is a statistics guru. He's actually an ER professor out of University of Alberta in Canada, but we were real fortunate to have him. But we used a zero-shot learning and greedy decoding. And what that means is that zero-shot learning means that we did not program the AI. We didn't give it any prompts. We put in the information just as the paramedics were getting it, so it didn't have the benefit of us prepping it. The other thing is the greedy decoding means that it's searching for the next word. So in a sentence, the cat is on the carpet. The cat is on the table. The cat is, so it's looking for that next word. And so based on that, we really were getting the pure AI diagnosis and how it was going to work. The other thing that I think is important in the study, and people that have read the study always question, and that's why I talk about the zero shot learning and the greedy decoding, is that the paramedics were given three opportunities for a differential diagnosis, while we gave chat only one opportunity. We felt that the burden is on chat. The burden was not on the paramedics per se. And so we only gave the AI product one opportunity. So this study also, one other thing that I think is important, this study was done in early 2024. And we've got to remember, I mean, AI is everywhere now. But back then there was 3 to 5 different models that were out there. OpenAI and Chat was the one, and it was only released in November of 2022. So by the time we're doing that research a year ago, there weren't many different models. Now, as of April of this year of 2025, there's over 15,800 different models. And so I would wonder what the outcome would be if we did it again today because of the exponential learning curve with AI. What was something else that you said that I think, oh, the results. 75% of the time chat was getting it right, but it's actually a little bit more than that, because when you take into account the right and wrong, where chat was seen as more correct, it adds another 10% there. So really probably 85 to 89% of the time chat was getting a correct diagnosis.
So ChatGPT is diagnosing our patients now. Let me just ask you, what do you think about, what this means for the future of EMS and AI technology? Because, as a paramedic, I am looking around at this new technology world, and I see all these folks who have jobs like, lawyers and accountants and people who drive for a living. And I think to myself, ha ha ha, I'm a paramedic. I am never going to have a problem where AI takes my job. But is this maybe telling me something different? I don't know. What does the
No,
future mean for what we're
no,
seeing here?
no. Trust me, we got jobs for a long time. I think that my concern is that we become lazy. And this is where the problem will be. AI AI diagnosis isn't coming anytime soon, at least to the United States, because there's huge liability reasons for that. The case law hasn't come out. Who is ultimately liable when the AI makes the mistake? There are some real legal hurdles there. Now, you mentioned earlier that the AI was more conservative than the paramedics. And that's what we found across, with the exception of one case. And in that one case, it was, I want to make sure I get this right. It was a 72-year-old female that was having some dizziness. She had a history of 2 TIAs in the past. And the paramedics, the first differential was, either a TIA or a CVA. But the one diagnosis from chat was vestibular neuritis and, inner ear infection, basically. And so that was probably a gross under triage. And if that patient was having a CVA and, you know, for whatever reason was left at home, who's liable for that? And until those questions are answered, I don't think we have to worry about chat or the large language models at this point putting us out of a job. I think some real good use cases are, though. We're seeing this in doctors' offices. I think we'll see it, if it's not already in some of the EHRs, is recording the conversations and then putting that language into our EHRs, our patient care reports. And how back in the day, and probably still, if you don't have somebody recording when you're giving medications, you'll have the timestamp now of actually when the medication was given and all those types of things. I think that is coming. If it's not, it's already here in some ERs where they used to have scribes, they now have AI, but even that's problematic. I've just read some patient care reports where it's a female and it says, he, or reports them as a male. So even that, my concern is our human nature to become a little lazy, not going and reviewing reports and having inaccurate reports. So
Well,
I,
and I just think that it's really strange that we are focused on an analytical model when we are conducting medicine. And the analytical model that we're looking at with AI technology is something that we can't comprehend. So even if it did something wrong, how could it go to a jury and the jury even understand the complexity of what went into the error? Or, because information in, information out, right? So when I'm thinking about your case of the inner ear infection versus stroke, I wonder about what specific information was on the input side. That's what I would want to, scrutinize. And
yeah, I went back and actually read that case again, and it most certainly said in the subjective that she had a history of two TIAs. I'm not sure what
Oh.
the model picked up on that made it think that it was basically vestibular neuritis, but felt that it should have been more conservative. But that was really the only
Mhm.
case that was that far out of, the standards, I think. Yeah.
So then the other thought is I'm imagining now that this kind of AI technology could be helpful when we dispatch calls in the dispatch center to decide what resources are needed before they come because already you have two callers on that line. Usually on the dispatch side, you'd have a person that listens that talks on the radio to dispatch, and then you have a person that talks to the 911 caller. And so there's already just a lot of complexity there, but that might be able to be simplified. And when we're looking at transport decisions about where a patient needs to go, I don't know that the patient care report could be put together fast enough, but I'm imagining a future where recording devices in the ambulance could summarize and take information that would indicate things. And it just all goes back to the fear of laziness. I have a friend who worked in New Zealand as a paramedic, and his job was a total solo gig where he drove the ambulance to the emergency, took care of the patient, and then and after doing the interventions, he gets back in the front and drives. And if someone's riding with the patient, it's the family. It's just a different thing, a different culture, but it's possible to do that job with just one person. And when we think about how monitoring devices are already so advanced, I mean, maybe we aren't going to get rid of paramedics, but maybe their EMT partners might, this is a lot to take in.
Yeah, I think, if we want to just think about how things could work, we already have CAD dispatching, so we're already using computer aided dispatching, and even the layout of where the ambulances sit is based on, historical data that the calls between 2 and 3 o'clock traditionally go here, and if one ambulance goes out, we're shifting around in municipal areas to try to give the most likely best coverage for the areas. Hell, sorry. Um, we've been using the 12 lead EKG. Now, nobody should be using it as their diagnostic criteria, but I mean, you get the 12 lead, the computer's extrapolating out what is this? Is this a fascicular block? Is this, VTAC? All of that kind of stuff. We've been using that since the 60s. Um, so I
Well, by the
think
way, the computer readout is usually wrong. We all know that.
right,
When
and
the
that that's
computer
that
tries
that
to
was
analyze
that was my that was my kind of hedge there, that you don't use that as your diagnosis. You may
yeah,
let it try to confirm, but you should never, kids, you should never allow that to, don't treat the machine, treat the patient.
right.
But as calls come in, and I worked for GMR, AMR, um, and their EHR now can pull the historical data from that patient, right? And I can see a time when we the 911 dispatch call comes in, we already know who the patient is before we get there. The symptoms, all of that are already put into the
Hmm.
EHR, and all of that could be malleable where you can change that kind of stuff. But we come in, the glucometer is used, the 12 leads put on, all of the vital signs are being real time put into this, and maybe it's even pulling a historical record of an ER. Who knows where this could go? And that is where AI will surpass the paramedics' ability to maybe diagnose, and even physicians, because of the vast amount of that information and real-time diagnosis is going to be too much for a normal person to assemble in their head. And again, I think for most of this, that 75%, 85%, that's uh, that's just easy because the patient is so easy, right? It's obvious what it is. Where we're really looking at AI and helping, in my mind, is that 2 to 5% of patients that, man, we missed something, that it's a really obscure diagnosis, that's where I think AI and these models will come in handy for those outliers that we may blow off. And it's not just paramedics, physicians do it, any provider where it catches something that we just miss, due to fatigue, due to whatever. And so I think that's where the model becomes a safety net rather than the primary provider.
Well, and getting, we need to get people to the right place so they can get the right treatment, especially when things are critical. So, heck yeah, if it's going to be able to help in that. And I just think about, though, the laziness part that we mentioned, and I compare that now in my mind to what doctors go through. So I see the emergency room doctor go in and listen to someone's lungs. And I wonder, is that just they're doing it for show because they're going to look at an x-ray? And same thing with, a patient with abdominal pain, that doctor is going to touch their belly. But is it really going to be the same belly touch that would have happened before CT scanners were around, right? Because that same a physician that wasn't going to have a CT scan might really evaluate that belly in a different kind of serious way, and it's because those touch aspects were the only thing available, and so now we have more. But is that more problematic because we aren't going to touch them as much?
So the problem you're talking about is analog care in a digital world. And so I still work PRN in an ER. I can't tell you how many times I've had a parent or a patient tell me, "Thank you for touching me. Thank you for listening to, their lungs or we have gotten away from even touching our patients, and
Yeah.
that's analog. That's human. And that's something AI will never replace. There's a big movement of AI counselors right now. That's great. Maybe it solves the simple problems, but sometimes you still need that human touch, and you need to know that somebody actually is there that gives a crap. And I think that's where um, we really need to focus as care providers. And that can never be replaced by a robot. That will never be replaced by AI. I think that, you just had an article in GEMS regarding quiet quitting, right?
Yeah.
And I think that all of this technology, everybody glued to their phone and TikTok and Instagram and all this other stuff has really changed our mental health and our
Mhm.
ability to connect with each other. And the one thing we really are trying to do, and where we're at in our profession, I've always felt it's a privilege to be in healthcare because we are meeting people at the base of Maslow's hierarchy of needs. We're at the bottom of the pyramid.
Mhm.
And it doesn't matter. I remember in Colorado Springs picking up a bum. Can you say bum? I don't know.
Yeah, we
Picking up
know.
a bum under the bridge, right? And my very next call was to a guy in the Broadmoor area of Colorado Springs, which is Beverly Hills, right? He had founded a Fortune 500 company. And I'm thinking this guy is getting the same paramedic as, this bum under the bridge,
Mhm.
but it's a privilege to take care of both of them, right? That we have such a privilege as healthcare providers and paramedics. I mean, my God, what a great job to go into people's houses. We're intimately into their lives, and they're telling us things that their best friends don't know. Hell, they're telling us sometimes things that their parents don't know or
Mhm.
their spouse doesn't know.
Mhm.
We are really privileged in what we get to do. And I think that we forget that. It's exhausting because now, it used to be you run 5, 6 calls, a day, and now you're doing over one an hour if you're in an urban setting. And it gets exhausting, but we've got to return to the analog of medicine and remember that we're in a digital world, but we're in an analog profession.
Well, thanks for geeking out with me about this
Hey man,
research stuff and
anytime. I
being with
love
us
it.
today. Like many of you, I'm also an EMS instructor, so I know what it's like to have topics that are important to cover but are not actually in your curriculum. So when it comes to EMS research, I want you to know that I've been joining EMS classes lately in a virtual kind of way. It's fun for me to meet your students and talk about EMS research or even talk about how things are done differently where I am versus where you are. So, if you're an EMS instructor like me and you want to give your students a flair of what EMS research is all about, just fill out the inquiry form on my website at professorbram.com. This is professorbram.com, and I'll be in touch. I want to also invite you to check out my latest book. I co-authored it with Four Arrows, who has 2 doctorates and is an expert on indigenous scholarship and hypnosis.
We've got to look at each individual patient as a human being who is in need. And we've got to know that when we're in need, we do look to others, no matter how self-reliant we are. If we are in a situation that we've never encountered before, that self-reliance begins to seek, is there anyone that can help me with this situation? I mean, you've used a pretty drastic example with the arm cut off, but I don't care how much skill you have. There's very few people who would be able to not say, "Oh my gosh, I need help," and then all of a sudden someone shows up
with a badge.
Yeah, and
Right.
you think, well, maybe this is someone that can help. Well, you said that, and I said that during the first hour of trauma, people are essentially in a state of what we now know is hypnosis state.
I want to invite you to check it out because we introduce a method for communicating with patients on the scene of the emergency that takes advantage of some of the properties found in hypnosis. The book works to change the way we approach and interact with any emergency patient who's in acute distress, and it can help you be a better practitioner. The book is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. Follow a link there below to find it, or you could get it almost anywhere books are sold. And if you contact me, I would be happy to mail you an autograph sticker designed to be put into the jacket cover.
Hi, I'm Will Chaplot from the International Prehospital Medicine Institute. You might know about us because of the literature reviews that we post every month free for you to review on our website at iphmi.com and also published through GEMS Online magazine every month. We've been doing them for 5 years, so now we've accumulated over 240 literature reviews over the past 5 years. And we've gotten feedback from our audience that said they'd like to have these things as desk references, so they'd had a rapid reference. Well, we've done it. And there are now 5 volumes of these books, one for each year that we've been publishing them. This is the latest version, volume 5. And as I said, in each of these, there's at least 48 literature reviews. They're all cataloged in the beginning of the book, so you can see what the topic area is, what pages those reviews are on, and how you can find them quickly. And again, these are a great reference, whether you're putting a lecture together, working on a paper, studying, whatever it is. This gives you the depth of field of the science that dictates what we do in the field, or what we should be doing in the field, or why we've changed the way we do things in the field. In any event, as with all of our publications, we've priced these because we want you to be able to have this book. It's only $4.99 in the hard copy here, and all 5 of them are available at that price. But you can also get them as ebooks, and they're available as ebooks from Amazon, from Apple, from Barnes & Noble, wherever you get your ebooks for the price of $2.99. So again, we don't do this with an aim towards getting wealthy. We do these because we want you guys to be able to have these materials, relevant information, affordable information, and an access so you can get to it. So you want the hard copies, go on Amazon, $4.99. Go to your ebook store and you get it for $2.99. If you're in the business, this is the kind of material you want to have around to settle those firehouse arguments or to help you put your materials together. Thanks again. See you all soon.
I'm doing a research project related to first responders who live in the United States, and I could use your help if you don't mind being interviewed over a video call. Go to my website and fill out the form. It's at professorbram.com, professorbram.com. I just want to thank you for listening, and I look forward to sharing more insights with you in the next episode. If you enjoy EMS research, please tell your friends and like, share, and subscribe to help others get the message.